Dear Chairman, dear ladies and gentlemen, we are pleased to present our work on the surgical management of lumbar spondylodiscitis. We do not have any disclosures. Although spondylodiscitis is considered rare, its incidence has been increasing largely due to an aging population and increase in comorbidities. Lumbar spondylodiscitis is a serious condition that carries significant risks, particularly when diagnosis and treatment are delayed. If the infection progresses, it can lead to severe septic complications and early neurological deficits. The main principle of treatment, particularly in cases where conservative management has failed, involves two key aspects. On the one side, early surgical debridement with drainage of the psoas abscess is essential. On the other side, it is crucial to reconstruct the anterior column with a stable construct. Our study is based on an analysis of prospective collected data in a level 1 spine center, where between 2015 and 2022, 310 patients with lumbar spondylodiscitis, including endplate destruction and psoas abscess formation, were operatively managed. The surgical treatment involved a combined anterior retroperitoneal approach, combined with a posterior percutaneous stabilization in the same surgical setting. The study involved 185 women and 125 men with a mean age of 64. A retroperitoneal approach was performed either from the left or the right side, depending on the psoas abscess formation. Anterior debridement and fusion was done utilizing titanium cages, combined with a posterior percutaneous stabilization. A post-operative antibiotic treatment was administered for 8 to 12 weeks. The patients received antibiotic therapy, which was targeted to the pathogen identified in the intraoperative tissue samples. All patients underwent an extensive preoperative imaging. This included X-ray, CT scan, and an MRI of the whole spine. Most patients already had a preoperative conservative treatment. Those patients received antibiotic therapy, which was targeted to the bacteria identified in the blood cultures. A single-level infection was present in 260 patients. In 50 patients, 2 or more levels were affected. The mean operative time was around 180 minutes, and the blood loss was around 360 milliliters. Fusion was achieved in most patients within 12 months. A persisting or recurrent infection was observed in 2 patients, both of whom required revision surgery. In 2 patients, an extension of the stabilization was necessary due to screw loosening. Anterior retroperitoneal approach is safe and effective option for the treatment of lumbar spondylodiscitis. The reconstruction of the anterior column using titanium implants combined with a posterior percutaneous stabilization allows for early mobilization and results in high fusion rates. Thank you.
Thank you for this nice series of 300 patients in 7 years. Nice reference center. Direct question from the floor? No. So, for you, why is it crucial for you to reconstruct the anterior column and not only use a posterior approach and let antibiotics do their job?
and reconstruction of the anterior column is often only necessary if in severe cases where you have endplate destruction and psoas abscess formation. When you have in the lumbar spine a spondylodiscitis with endplate destruction and psoas abscess formation, it's much easier to address both via a retroperitoneal approach, because you can do a blunt dissection of the psoas and drain the abscess, and also reconstruct the anterior column in the same way. Yeah.
Okay. Another question: will you use vancomycin locally, or in general?
Yes.
Vancomycin locally?
Yes, together with the bone graft.
Okay.
Yes.
Where do you use the bone graft from? There was
Iliac
another question.
crest.
Iliac crest.
Iliac crest. Yeah. We mix it with vancomycin or gentamicins. Yeah. And then we put it in the defect.
So you open the iliac crest and scrape it out, or you take a piece of the iliac crest?
We take a piece of the iliac crest.
And what is your attitude for persistent infection? Do you remove all the material, or?
You mean if after surgery the infection persists?
Yes, if there was a persistence.
Yeah, in 2 patients it was necessary to do a revision surgery. In these cases, the infection extended the intervertebral disc space where we put the cage, and we had to do a corpectomy because the infection was so severe. There was even more bone destruction. Yeah.
And then you would take out the metal or change the metal?
Yes, we take out the titanium cage, which is intervertebral, and we had to perform a corpectomy.
Okay. Well, now in the last talk, you all posed 20 questions, and in the first, no questions at all. So it seems to be spondylodiscitis is still a very hot topic. There's maybe a general question. 3 or 4 questions are on what's your indication? So when do you consider conservative therapy to have failed?
That's a very good question.
And when do you consider? It's obviously a very difficult question. Maybe a short overview, and when do you go for surgery?
Answer. Most cases of spondylodiscitis can be treated conservatively. Only in cases where you have severe bone destruction, which leads to instability, or when the infection extends the disc space, goes to epidural space, meaning you have epidural abscess. In these cases, we see neurological impairment. Then I would suggest surgery. When there's instability, surgery. But if it's a mild form, conservative therapy is the first way to do treatment. I also showed that 90% of patients already had conservative therapy. Either we initiated it or the referring hospital already did the conservative therapy.
I think we probably have to move the discussion to later on, because now people in the audience argue that there was not significant bone destruction on some of your images, and some are asking how do you define severe instability? So these are still obviously it's a gray zone. Let's maybe sum it up to that.
Yeah, and I'm open for discussion. You can talk to me, it's no problem.
And prepare, because there are questions on bacteriology and germs too, so prepare yourself.